Hi everyone, welcome to Clinical Vignette 2, an overview. I have written a detailed overview under announcement, so if you have not checked that out, please go and read over that. It's really helpful, but I am going to go over it in this video as well. And so I want to clarify a couple things. Vignette 2 is the final paper. It's going to begin at the end of your Vignette 1. With that being said, Vignette 1 should be edited with the corrections that I propose to you. If you have questions about any of the comments that I left you, now is the time to reach out to me, definitely this week as early as possible, so we can make sure that you're on the right track. Also, the paper is a max of 12 pages. I have a deadline of when final grades have to be submitted, and so I can't read 20-page papers and get everything edited and back to you in a timely way. So max 12 pages, which means you have to condense Vignette 1. I gave some of you feedback on how to do that. You can definitely reduce the identifying information section. You can also reduce, you can also reduce the background information. I mean, some of you did have over a page for identifying information, and it doesn't need to be that. It can be a paragraph. My daughter's home today, so you might hear her in the background. The background information is definitely what you can decrease. If you have questions, you can let me know, but max 12 pages, okay? And so it must be APA style also. And what else is there? Okay, so you want to reassess individual based on everything we've covered so far. You're looking at the same client, nothing changes about that, but you're looking at this client through the lens of the information that you've gained. So we've gone over trauma assessment, we've gone over anxiety disorder, depressive disorders, mood disorders, also how to evaluate based on a holistic model of environmental, social, psychological, and biological factors, also environmental if I missed that. You're looking at the client through all of those lenses. Now, some of you may still find that you have the same clinical impression and the same primary diagnosis, but for some of you, it may have changed. So we'll get to that. 3 references can be are required. 3 references can be peer review articles. It can be professional websites like SAMHSA that you looked at last week. Anything like that is fine. For the model of this course, you're supposed to have 3 additional references, not including the DSM-5. That should be no problem. Let me know if you have questions. You can use professional articles and sites that were in this class. If it's relevant to your paper, your patient, that's fine. I'll allow that. Again, so you have your Vignette 1 should be edited. This first section is Vignette 1, right? Your edits. Then halfway through and Vignette 2, okay? So you over Vignette 1, you reassess the client, like in your mind, right? So you think about what still stands to be true and what's shifted, okay? So when it says look at challenging behaviors, these are already defined from Vignette 2. You can move that paragraph here if you'd like. You can just move it in your Word doc. That's fine. But you want to look at if anything about the behaviors has shifted, okay? And then next, state what behavioral manifestations may relate to diagnosis that we've covered in the class. Okay, so this is saying, are the behavior manifestations or challenging behaviors what you thought they were? So some of you describe patients that had trauma histories. So is their attention-seeking behavior that you listed truly attention-seeking, or are they acting out old patterns learned? So you would comment about that here. Again, I'm not asking you to address every diagnosis or symptom that we've covered in class, just the ones that are relevant to your patient. So some of you talked about patients that have a mental health challenge now based on an accident or injury that they sustained. So you would talk about that. Are the behaviors that they have as far as their mental health, is it simply them being in a terrible mood or acting out, or is it really long-term grief because they are starting to realize how different their life is going to be? The fact that they may not attain some of the goals that maybe they wanted in their youth. I mean, perhaps getting married or having children or even being able to travel. Does the injury or circumstance limit their current options, right? That could be presenting itself as depressive symptoms that you should have listed, but is it really that? So that's what I'm asking you, to conceptualize the symptoms and comment if you think the symptoms are trauma-based or stress-induced or, caused by a medical crisis. Like, I've written this out for you guys, also have as you're writing the paper. Okay? So next, when you assess the person, you determine 2 or 3 differential diagnoses. Okay? So I'm just going to go over this briefly. Let's just say your client presents with PTSD, but they also have symptoms that could possibly justify, like a reactive attachment disorder or adjustment disorder or even mood disorder. You would list your 2 or 3, and that's it. That's all you need. 2 or 3 possible differential diagnoses, and you would, in the next part, give the rationale for each differential diagnosis. Again, stick with 2 or 3 because you have to offer your rationale. Some people listed multiple diagnoses in Vignette 1, but then didn't really justify how they felt around the clinical justification of the diagnosis. And again, that's based on what symptoms your patient has that you've listed that match the DSM criteria. This is not opinion-based. This is what your client, what the behaviors are matching with in the DSM-5 criteria, right? So that's that section. Give the rationale. Make sure you're clear and concise. Again, this is not opinion. The behavior should back up with the DSM-5 criteria for your diagnosis, and you only need 2 or 3. Next, make a list of the ruled out diagnosis. Again, 2 to 5 is fine. I mean, you really only need a couple here. Some people listed several, but the behaviors and the symptoms that they listed for their patient didn't back up the proposed ruled out diagnosis. What I mean by that is, if you are presenting somebody that has like depression and some trauma-based stuff, you don't want to rule out like inhalant use. You would have to paint that picture. You would have to show me how you came to that realization. If they had substance abuse disorder in the past and they used various drugs, then you could rule out inhalant use disorder if you stated, we did a urine test or a blood test to screen for various substances and alcohol. It was negative. You see where I'm going? You would want to paint the picture. You shouldn't have just random diagnoses that you're ruling out. They should be focused, right? And so if you had like major depression, it would make sense, and you could make the case that you ruled out mood disorder, generalized anxiety disorder, and I don't know, dysthymia, which is persistent chronic depression, basically, right? So all of those have similar symptoms, but your patient, you're justifying that the patient didn't meet the criteria for these other related diagnoses, okay? If you have any questions about this, reach out to me. We can talk through your individual patient. I can help you narrow this down. But you don't want to lose points here. This is really simple sections that you can get all of the points for. The next section is based on the person's life experience, identify diagnoses that the person may be at risk of developing. Again, here you don't have to over embellish. If you have, for instance, a patient with a history of trauma, what's going to happen if they don't treat the trauma? What's going to happen if they don't comply with treatment? So what we know about trauma is that many people that have trauma symptoms will self-medicate if they do not receive proper treatment. If they don't have a certain level of stability, they will tend to self-medicate. It could be with drugs and alcohol. It could be with promiscuity. It could be with risky behaviors. It could be with other medications, overtaking them or whatnot. So you want to talk about what the person is at risk for, and whatever symptoms they have, if untreated, could worsen. So a person that has, depression, it could grow into persistent daily depression, which could decrease their level of functioning, that kind of thing. So talk about this here. And then lastly, you want to list the current medication. This may be the same as in Vignette 1. The only thing that would be different is if the diagnosis changes. So if from Vignette 1 to Vignette 2, you feel the diagnosis is no longer consistent, you might say, the client has been encouraged to have a psych med management appointment, psychiatric med management appointment to review medications, right? So if the diagnosis changes, it's possible that the medications may change depending on what the changes are, okay? So summary section is going to be the most. It's not even. Sorry, daughter came in. Again, for the summary section, you want to make sure you're addressing each of these stated questions here, right? So for A, discuss how you resolve differential diagnostic challenges. And so you want to talk about why some of the diagnostic behaviors or diagnoses that you ruled out, why did you rule them out? Talk about there being sufficient or insufficient criteria here, okay? So also think about this in terms of, like for PTSD, they have to meet one behavior or situation from each of the categories. There's 3, right? And so one of them being, there has to be like a specified traumatic event that happened, right? And so let's just say for a different disorder, your client met 2 out of 3 of the required criteria. You want to talk about what the client didn't meet and how you resolve that, right? So resolving it meaning perhaps that's not an accurate diagnosis, or perhaps you would talk about the client has symptoms of post-traumatic stress disorder, however, they did not meet all of the criteria, and therapeutic treatment could still provide psychoeducation to help the patient deal with, let's say, hypervigilance or flashbacks, even though they don't have the diagnosis, okay? Also, I put here, a person may have multiple diagnoses. There will be a primary diagnosis. So again, a person may have like major depression, but they may also have anxiety symptoms, but they may or may not fit the criteria for a generalized anxiety diagnosis. You want to talk about that in this section. Again, if you have questions, please let me know. So next, as you're working through the differential diagnosis, how has your view of the individual or patient changed? Be clear about this. What has shifted? Do you have more empathy? Are the symptoms that you thought, again, were maybe attention seeking, are they actually trauma-based? Or are they a result of long-term substance use? And so there needs to be like some life skills and coping skill management involved there to help the person to cope better. Did the person have significant suppressed trauma that they didn't deal with for a really long time, and so they got really used to kind of being in survival mode, but throughout this assignment and your work with them, quote unquote, how have you learned about them in a different way? And so sometimes the most difficult people show us how much compassion and love they did not always receive. And so their difficult behaviors can be based on a way that they have found to cope. So they're like defense mechanisms or coping skills, even if they're quite challenging, right? And so be sure you talk about your experience with that here, with your patient that you have in your paper. Next, how has your view of the presenting problem changed? Is the problem truly the problem, or is it a side effect? And so, again, we've talked about that. Discuss if you feel the problem that you thought the patient presented with is still the problem, or is it a symptom of something else? Did they come in with low coping skills, low tolerance for pain or difficulty? But again, is it the result of trauma? So their emotional maturity is lower than maybe their actual age or status in life. If the person came in, some of you have patients in your paper that are adolescents. Did some of their behaviors signify challenges at home, or poor attachment, or even you may have found that there were issues with the child at a younger age that were never resolved. So now they're just coming out on a larger scale, but proper treatment, play therapy, psychotherapy, nutrition, like some of those things you have found has helped the patient, and now you're seeing it differently. Make sure you comment about your change in perception here. Even if there maybe hasn't been a change, but you have more empathy after learning kind of what trauma really is and how it shows up and how difficult it can be sometimes for a patient to seek treatment, has that changed your perspective? And so next, how has your expectation of the client changed? What has changed about how you treat them or what you expect from them? That can be different based on the diagnosis, also the client circumstances. We'll talk about that here. And so trauma is a big piece with this. Sometimes when you learn of a client's history and you learn how much they've been through, you definitely don't pity them, but you have much more empathy for their challenges and for their willingness to continue to show up and to seek treatment. And so the next one is, what's the view of your original diagnosis? Next, how has your view of the person's diagnosis changed? Is it still consistent with your first impression? Explain how it shifted. Any questions about that? Let me know. What has changed for the client? Discuss their attitude or the treatment protocol, any compliance issues, even their mindset. Talk about what has shifted, and address any countertransference that you felt towards the client. Again, I have offered feedback for the week 5 discussion on this. If you have any question about what countertransference and transference is, please reach out and let me know. But I'm looking for a clear, concise answer here. And also talk about if you have more empathy now, and even if you found where you have more work to do for yourself, like more healing work, or even looking at different cultural or diversity issues. Do you have some work to do around that? Did something come up for you and working with this particular client or population? This is a good place to talk about that. And so again, the things I mentioned in the beginning, have your 3 references. Please use APA style. For some of you, I have mentioned seeking help from the Writing Center. If you haven't done that, please do. If I made that suggestion, if you need certain questions asked, please feel free to reach out to me in the next day or two, so you can get a jump start on writing this paper. There shouldn't be like typos in this paper. It's a graduate level writing. You had a chance to make revisions if needed, depending on your grade for Vignette 1, and I have offered support in helping you with any issues you had with the editing of Vignette 1. So if you do all of that, you're going to be in really good shape for this paper. If you haven't, you want to get started on that stat and see me with questions. You guys are really all doing well, and I am very proud of your work. And so again, you don't have to redo Vignette 1 for this paper. You're just adding Vignette 2 to the paper for a cumulative final paper. If you follow this rubric, you're going to be fine. Make sure you answer all the questions. You can be clear and concise. 12-page max is enforced. If you have any questions, please let me know. Thank you.